What if one treatment could deliver 96% 10-year survival in metastatic melanoma responders? TIL therapy is redefining cures. Engineered TIL hits 67% responses in PD-1 refractory melanoma. Safer, stronger, and a potential game changer. We unveil the breakthroughs with Dr. Allison Betof Warner, melanoma trailblazer at Stanford. In 3, 2, 1. How did lifileucel help about a third of patients with melanoma resistant to PD-1 treatment live longer without their cancer growing back, based on the 5-year data?
Yeah, so lifileucel is right now the only approved treatment for PD-1 refractory melanoma. And the idea is to use the immune system in a different way than standard checkpoint inhibitors. And so we take out a patient's tumor, isolate T cells from that tumor, and then grow them up in a lab with the goal of flooding the system with good antigen-specific T cells that go after the patient's tumor. And the 5-year data really suggests that with this one-time treatment, about 30% of patients will have their tumor shrink or go completely away. And of those responses, many of them are durable even out to 5 years, and we expect far beyond that, without getting any additional treatment for their melanoma. And the idea is, again, that we have taught the immune system to do what it needs to do to control the tumor.
In the TIL 301 trial, how might measuring overall response and progression-free survival show if lifileucel works better than other treatments?
So the TIL 301 trial is a frontline trial for metastatic melanoma that is comparing lifileucel plus standard immunotherapy, pembrolizumab, with immunotherapy with pembrolizumab. And so the idea is that patients are randomized 1-to-1 to either get this TIL treatment plus a checkpoint inhibitor or the checkpoint inhibitor alone, which would be the standard of care for our patients. And we will need to see the data mature, but if that is superior, not only does that validate TIL as a long-term approach, but additionally really, will make us think about moving TIL even earlier. Right now, TIL is second line or beyond. And the question really is, should this be considered earlier for our patients as a frontline treatment?
What is OBX-115? And how could it make TIL therapy safer by using a special protein instead of high-dose IL-2?
So OBX-115 is an engineered TIL cell product with the idea of engineering in the ability for the cells to make their own cytokines so that patients don't need to get high-dose IL-2. So these cells are engineered with a drug regulation domain that responds to carbonic anhydrase. If you give the patient acetazolamide, that stabilizes the IL-15 that is produced by the cells. That IL-15 translocates to the membrane, binds to the IL-2 receptor, and is the stimulatory signal without having to give the patient systemic cytokine. This was recently presented at ASCO by Dr. Jason Chesney in the phase 1 data that showed really early promise in a small number of patients, but a 67% response rate in patients treated with PD-1 refractory melanoma who were treated at the recommended phase 2 dose. So the phase 2 trial is open and accruing. We're actively treating patients to really see not only is this approach potentially more efficacious, but also potentially safer than standard unmodified TILs.
How might improving TIL therapy, like making it safer or using it for other cancers, change treatment options for patients in the future?
So, until TILs were approved for solid tumor, aside from surgery, there really wasn't a one-time treatment for our patients, right? If you were diagnosed with metastatic cancer, the expectation was that you would be on treatment for weeks, months, or years even, and sometimes indefinitely when we talk about chemotherapy. And TIL therapy is really the first time in solid tumors that we've seen a systemic therapy that is a one-time treatment option. The goal now is to bring this not only to make it better in melanoma, but to also bring it to other cancers. We are starting to use TILs for non-small cell lung cancer in a variety of trials. We've seen trials in head and neck squamous cell, in cervical cancer, in breast cancer, and we're really thinking about how to bring this approach, whether it is TILs or some engineered type of cell to our patients. We've known for many, many years that patients with hematologic malignancies benefit from a one-time treatment in CAR T cells. And we are trying to bring that promise to our patients with solid tumors.